Hello, everyone, and welcome to the Induction Equation. I'm Alicia Fischbein, your host, and today we have with us Dr. Stu Fischbein. Hey, Stu.
No relation.
Eggs. I was just going to say that. I wish we were related. We're not. Let me tell you a little bit about Dr. Stu before he dives in. He has been practicing obstetrics for over 40 years. He's co-author of the book Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife, and a Mom, and peer-reviewed papers on home birth, home breech birth, and very soon on home twin birth. After completing his residency at Cedars-Sinai Medical Center in LA, Dr. Stu, as he is known, spent 24 years assisting women with hospital birthing, and then for 13 years was a home birth obstetrician who worked directly with midwives. Today, he travels around the world as a lecturer and advocate for reteaching breech and twin birth, respect for the normalcy of birth, and honoring informed consent. Welcome, Dr. Stu.
It's good, always good to be back with you.
Good to have
Um, it feels like home.
you. You're so nice.
No, it does.
Aw, Stu, not just because we share a last name.
No, no, it has nothing to do with it. It just
Aw.
I've been watching you and Meredith and following you and reading some of the wisdoms you put out every week, or even more than once a week, I think. Um, and the programs that you put together are changing lives. And the fact that I get the privilege of addressing another audience to maybe make some small ripple effects makes me very happy. Sort of that's my life mission at this point, since I'm, no longer actively attending births. Um,
I'm so grateful.
Age does catch up with all of us, and so it's really nice. So I just go and I teach and I advocate and I do consults and things on virtual consults and things like that. So and then I get to reach out to people through great people like you. So thank you.
Thank you. So glad you're doing what you're doing. So, Stu, we're going to talk today about some of the, Meredith and I like to call them birth hijackers. And there are many. These are the hijackers of normal physiologic birth. And two that come to mind are late pregnancy ultrasound and NST or non-stress test. So let's dive in.
Well, like everything else, we have to put a disclaimer at first and say, like a broken clock, every now and then, sometimes things that the medicalized birth model does save a life or does find a problem that might have been missed otherwise. There's no question that that's true. The question is, knowing that birth is not always a perfect outcome, knowing that no matter what you do, there's potential for a problem to develop. Um, is the interventions that are the interventions that have been put in place doing any good?
Mhm.
Or are they doing more harm than good? And we could end the podcast right here, because I will tell you in general, for just about everything that they do is more harmful than beneficial. And that's been true for, most of my lifetime. However, I mean, even beyond my lifetime, but it just took me a long time to realize that, because we were trained to believe that doctors know everything about obstetrics, and that your doctor has only your best interest at heart, which unfortunately is not true. Um, and that medical technology and medical intervention is designed to get better outcomes. And if that were the case, then we should be seeing better outcomes, but we're not. So there's something amiss here. And it's not because the American woman is unhealthy, or, isn't following instructions or whatever. It's because the system is broken. And some of those things that you're talking about, the hijackers, are the overuse of modalities of testing that have some limited use. These things started out sort of with a narrow window of indication. And what happens is they end up with mission creep. And because they all generate revenue for the system or the doctor or the hospital system, um, then there's no downside to doing them. And because what seems to matter most to the medical model, I've summed up in one sentence, which is all that matters is a live baby in the bassinet. And how that baby gets there and what happens to that baby, that mother, and that mother's future babies are not the concern of the people that run the hospital, the risk managers, the administrators. It's not concerns of the insurance companies who pay the bills. If it was, they would then try to lower C-section rates. They would try to do things that had better outcomes. They would look at the fact that we've gone from a 5% C-section rate to a nearly 35% C-section rate, and in some countries, 40, 50, 60, 80% C-section rates, with no concern about what that is doing long term to our species and to our children. And we know it's not debatable that we have the sickest, most chronically ill group of children in the history of recorded history, um, with over 50% supposedly, based on people that I trust, of children having some sort of autoimmune disorder or attention deficit disorder, or uh, which may be an autoimmune disorder actually, um, or eczema, or autistic spectral disorder, or Crohn's disease, or asthma, or childhood diabetes, or whatever, than we've ever seen before. Now, there are lots of potential variables for that, including how we're born, which is what we're going to talk about, and but also food. Things are spraying in the air. Things are injecting into our bodies. Things we're eating and taking in orally. 5G, who knows? You know, we're being bombarded by things that we were never bombarded with before. But it does parallel the rise of interventions. And even though causation isn't always, or correlation doesn't always mean causation, in this particular case, there's enough evidence out there that what we're doing is affecting the neural development and the microbiome of our babies, that it is directly contributing to some of this chronic disease stuff that we're seeing.
Yeah, this is, I mean, and this is why birthing moms get to consider so carefully these kinds of things, because making a choice to do an ultrasound, for instance, could lead to a slew of other interventions. So choosing wisely, choosing carefully, everything she does choose.
Yeah, well, this is the issue. So today you wanted to talk about like antenatal testing, I guess is what it would be the umbrella category of this. Ultrasound, we can start with ultrasound first, right? Again, ultrasound had a very narrow window of use initially, right? Does a woman need an ultrasound to have a baby? I did a podcast once called How Many Ultrasounds Does It Take to Make a Baby? And that was my cynical, sarcastic point of view, is that you can have a baby with no ultrasounds. And in most of the world, that is actually the case. They don't have access to the ultrasounds here that we have here. Now, does ultrasound do good? Yeah, sometimes it can do good. It may find something early on that has meaning and that may alter the course of your pregnancy, like an anomaly or like a placenta previa or some other issue, but that would have been discovered down the road anyway. Does it really change the outcome while you're pregnant? And the question is, I mean, it's not even a question because it does, because it puts the mother on a state of high alert. I'll give you a very simple example. At a 20-week ultrasound, they may find that the baby looks perfect, the baby's growing perfect, the placenta's in a perfect spot, but one of the kidneys is slightly dilated. It's called pyelectasis. And in the face of normal everything else, and probably a normal genetic screen called NIPT, which is done at like 12 weeks or whatever, it means absolutely nothing. But what the woman will be told is everything looks great, but your baby's kidney has a little bit dilated. So I want to see you back in 6 weeks to make sure that it's gone. Now, what's the woman thinking about for 6 weeks?
Stressing about this,
What's that?
stressing about it.
Yeah, stressing. I'm sorry, I thought you said trusting. No, no, they're stressing about the one thing that doesn't mean anything, and they didn't even hear the words that your baby is perfect
Yes.
because they're focused on the one thing that doesn't mean anything because the doctor one, wants to be honest and say, this is what we found. But two, there's no reason to follow up scan on that. What are you going to do differently the rest of the pregnancy? Right. You're going to make the mother worry, and you're going to make more revenue for yourself by having her come back. And then she comes back at 26 weeks, and now you find, the baby's abdomen has fallen off from what it was 6 weeks ago. So now we need to see you back here in 3 weeks to do another scan. And then, as you said earlier, this leads to this whole sort of chain of events that leads to more fear, more anxiety, bathing our babies while they're developing neurologically and anatomically inside of us with our stress hormones rather than our love and joy hormones. And who knows what that does, but it can't do anything good. Mammals don't desire to be stressful all the time. They prefer to feel safe. That's what they do. So we're doing something, but with, again, no consideration of that. That is not something that would be ever taught in medical school or residency about how to approach a woman and keep her happy and calm. Wouldn't that be nice? But they don't do that.
Mm.
So again, ultrasound, if it finds something like a placenta previa, that's very interesting. But what would have happened if you didn't find it? Maybe at 28 weeks, she would have had a bleed. And it wouldn't have been because she had sex with her husband. It wouldn't have been because she was picking up her 2-year-old. She would have had a bleed. It would have been scary because blood coming out of the vagina at any time is, when you're pregnant, is scary. But and she would have gone to the hospital, and it wouldn't have been catastrophic, and they would have made the diagnosis, and now they would have given her instructions about what to do differently. But for the 8 or 10 weeks that before it happened, she wouldn't have been thinking and worried about it the whole time.
Well, that's Stu, isn't that part of the problem? Because placenta previa is often diagnosed at 20 weeks, and that's too early to diagnose it. Women are going in for their I'm told I might have placenta previa when really if you just give her a few more weeks, everything's going to shift.
Yeah, I mean, 100% of let me make sure I get this right. I think 100% of anterior low-lying placentas resolve if they're seen at 20 weeks, and over 90% of posterior ones. I might have that backwards, but it's some really ridiculously high number that resolve. And even partial previas will almost all resolve.
Mhm.
Central previa, maybe not.
Mhm.
All right. But again, you're right. Most of them are going to resolve, but it's kind of like, you know, it, I use this example all the time in the movie Inception when they're trying to talk about how they're going to plant this idea in the guy's head. Why they say, why can't we just say it? And they say, because he'll know where it comes from. And they say, what do you mean? And they say, okay, don't think about elephants.
What are you thinking about?
Okay. So you have a placenta previa at 20 weeks. You tell the woman she has a placenta previa. You may tell her that it might resolve, but she's not going to think that it's going to resolve. She's going to worry about it.
Absolutely. I can't tell you how many interviews over the years I've done with women right around the 20-week mark. They're fresh out of their ultrasound. And they tell me, I've just been told that I have a low lying placenta and I may end up needing a cesarean.
Yeah.
Like, oh my Atlanta. No, that's one of the first things that they say when they're talking about their pregnancy and themselves. So yes, it takes front and center in their minds and hearts.
And it's almost never the case. Now, the question is, do doctors know this and say it anyway, or do doctors not even know this? Neither one of those is acceptable, by the way. Um, but I think the doctors live in fear
Mhm.
and they never want to be wrong. And so they always, I like to say, I mean, this is a term I mock sometimes. They like to err on the side of caution. Think about what that really means. It means to make a mistake, to be cautious. That's what it means. So, in other words, we'll make a lesser mistake to be cautious. That's not an ideal way to practice medicine. Anyway, so back to ultrasound. So that's like a second trimester ultrasound. If somebody was going to ask me, should I have an ultrasound? I would say, yeah, the anatomic screen is a very reasonable ultrasound to do. Question of again is who's doing it and what's their reputation and what's the likelihood that it's going to lead you down this path that we just discussed, or is it going to make you feel reassured? Some women are going to feel very reassured because they've been told everything's normal, and there's a lot of benefit to that because everybody worries. I mean, that's the human condition in in 2024 is we always think of the worst case scenario. But I'd like to assure your listeners that nature does it right most of the time.
Absolutely.
And when it doesn't, you don't necessarily need a second trimester ultrasound or anything else to tell you that. It will be discovered at some point when when you can. It doesn't really matter that you found it at 20 weeks. Sorry.
What is what can we oh, you're great. What could they potentially find at 20 weeks that would actually be useful, where knowing would be important?
A lethal anomaly, maybe
Mhm. Yeah.
that where a woman would have a choice to potentially terminate if she wanted to.
Any
Twins.
Sure. Okay. Stu, can you name some lethal anomalies?
Well, I'm talking about like maybe a diaphragmatic hernia
Mm,
where the lungs were not going to develop, or something like Potter's syndrome where they have no kidneys. Those babies will, they can't, they don't live.
yeah.
Some cardiac anomalies are essentially lethal or would require immediate surgery. Very rare. I mean, we're talking about zebras, not horses,
Yeah.
right? But there are certain things. But again, what doctors and maternal fetal medicine doctors look for are things that, you're right, don't mostly matter. And they'll spend a lot of time looking for it. They'll turn on another thing that they do is they turn on the color flow Doppler. Color flow Doppler is a higher level of non-ionizing radiation, and we have no studies really that show that ultrasound is safe in pregnancy. There haven't been any for at least 30 years. Uh,
Wait,
so
why aren't there studies on ultrasound?
because they don't want to do them,
Wow.
right? I don't know exactly whether they believe it's an unethical thing not to offer a woman an ultrasound, or to randomize people into ultrasound and no ultrasound, or how do you do it? So, and by the way, I don't know that they'd want to find out.
Because they're
Seriously, this is about why a lot of research isn't done. Why didn't the CDC investigate the difference between vaccinated kids and unvaccinated kids in their health conditions? That would be the classic study that you'd think that our government watchdog agency would have done. They didn't do it. It took other entities doing it. And if they did do it, they probably found out that their vaccinated kids were worse, and they probably buried it, like they did with the measles, mumps, and rubella stuff. With Andy Wakefield and William Thompson, and the things that were covered in the documentary Vaxxed, that sort of thing. So, yeah.
what do we
So
know
color
from
flow Doppler, I want to just talk about that for a second, because you're going to see your MFM turn it on. And they're going to look for tiny little variations in the blood flow vessels, and they're going to look at where the cord inserts, and they might find that the cord inserts marginally, or it might be even a velamentous cord insertion where the vessels splay out beforehand. Now you've got that to worry about, right? But do you do anything different the entire pregnancy for that? No. Do you deliver them early? No. Do you induce their labor? No. Do you do a C-section for that? No. So you don't do anything different. Most cord abnormalities or placental abnormalities are found when?
after birth?
After birth. The placenta comes out and everybody goes, oh, wow, look at that.
Yep.
Right. It's because the nature has designed a system that doesn't fail very often.
Yeah.
And, every time, by the way, and this is a very strong premise in medicine and in life in general, when you interfere with nature's design, there may be benefits, but there will always be downstream consequences. You will always have something that will happen that's probably not what you intended, whether it happens immediately or down the road or years later. We're finding out, obviously, throughout history of medicine, we found that we've given things we thought were going to be good to people. I'm going to give them beneficent motives, um, that turned out to be dangerous, whether it's thalidomide or DES or heavy metals in baby's teething powder, or putting the food pyramid upside down, or Vioxx, knowingly putting Vioxx out there, knowing that it doubled the risk of heart disease. Um, uh, the whole vaccine schedule, all these things, antibiotics, brilliant discovery. But it's created new problems because there are bacteria now that become more and more resistant, and they have to come up with more and more different antibiotics that sometimes have other side effects affecting your microbiome, affecting your gut. Zach Bush talks about if you give antibiotics to somebody, their rate of depression goes up. And he goes into the mechanisms of that, which is beyond the scope of our talk. But so these are things that nobody's looking at because all they want to do is sell antibiotics.
So everyone's forgotten their oath to first do no harm.
Well, that was never the oath of a pharmaceutical company, by the way, just so you know.
Just for physicians.
I don't know that they take that oath anymore, quite frankly. Yeah, my own medical school gave up the Hippocratic Oath. So color flow Doppler had a very narrow use, but now it's turned on with every ultrasound. Why is it turned on with every ultrasound? Because they can bill for it.
Hmm.
Because it's not necessary in a screening ultrasound. You don't need it. It doesn't give you much predictive value of anything, and there are so many false positives.
False
This is
positives,
the,
like
I'm sorry.
what kind of false positives?
Well, let me give an example for you know there's things called sensitivity and specificity. People have heard of them, but a lot of times they don't know what it means. Sensitivity is a test that's positive when something is wrong. Perfect example of that would be the metal detector at the airport. Okay, it's very sensitive. But specificity is a test that's negative when nothing is wrong.
Hmm.
So metal detector, high sensitivity, poor specificity. Keys, belt buckles, watches, whatever. So they're making them better now, but still, you have to still take everything off to go through those things. So the same thing happens with testing in medicine. You want a test that's highly specific because that means there's no false positives. When you have low specificity, you have high false positive rate. So this test has very low sensitivity. It has
So,
low sensitivity and low specificity,
wow. Okay.
right?
So there's no purpose in it when they're both low.
No, there's no purpose as a screening tool. It was never meant to be a screening tool. It has become a screening tool because it increases revenue. And they'll find something because sometimes, something like uterine artery notching,
Hmm.
which can be a predictor of preeclampsia and growth restriction, is often seen normally at 20 weeks. But they'll see it and they'll say, oh, well, we saw it. Maybe it's normal, but maybe it's not. Why don't you come back in 4 weeks or 6 weeks and we'll look again?
Yes.
This is how it works. No concern about what that's doing to the mind of the pregnant woman and her family. They
Yes.
don't care about that.
Not to mention the baby's exposure to that level of ultrasound.
Unnecessarily, correct. So this is one of the problems with, and we haven't even gotten to the third trimester yet. So we probably should keep going here.
Yeah. Tell us.
Uh, so if we get to somebody says, well, they're 36 weeks. Let's just do a scan to make sure everything's okay. What about that? Well, women like to see their baby, so they're going to say, sure. They're not going to think about the downside of it as far as exposure, which again, we don't really have clear indications for, but you have to assume that you're exposing your baby to something that isn't natural. And therefore, there's going to be some downstream consequence to that. We don't really know what it is, but it may be contributing to some of the problems that children are having. That the use of ultrasound has paralleled the rise in chronic illnesses in children too. So you have the ultrasound at 36 weeks, and then they say, okay, but then they find something. Oh, your baby's fluid is a little on the lowish side. Oh, your estimated fetal weight is too small. Your baby's too big or too small. And it's one of the things that's really irked me since 2020 is they changed the definition of growth restriction.
Oh, how? Tell us.
Yeah, growth restriction is now a baby that's less than the 10th percentile.
Really?
So think
Huh.
about that for a second. What a maternal fetal medicine doctor is telling the population of women is that 10% of babies are growth restricted.
I-
That's insane.
Any sense?
It's a bell-shaped curve of normal.
Wow.
A growth restricted baby is a baby that's falling off its growth curve. And you could have a baby that's at the 20th percentile that's struggling because it used to be at the 80th percentile. And
Mhm.
then that will not be picked up by this thing, but they'll still keep bringing people back, anybody less than 10th percentile. Used to be less than the 3rd percentile, along with some other factors. But they
Mhm.
raised it to the 10th percentile. Why not? Why not raise it to the 20th percentile? Then they can do more scans on people. You wonder, you wonder why they do this. They raised it so that they could increase sensitivity, but they ruined specificity by doing that. But they don't care because it's more revenue. By the way, I keep coming back to that theme, and that is a huge part of the whole scheme of antenatal testing is the revenue that it generates. And then ultimately we'll get to the question, does it do any good? Which is where we'll hopefully we'll end up. So you get this ultrasound, and there were papers that have come out. And again, I'm not a big fan of research because I can't trust it anymore. Research is often uh, monetarily motivated. When you see a paper, you have to ask yourself who wrote it, who sponsored the paper, and why is the paper coming out now? And
Yes.
and then you have to read the material and methods section to look and see how many people were in the study, because the conclusion or the headline that might be in the New York Times might have nothing to do with reality. It might be they're selling something, they're promoting something. So science is very difficult. But there were papers that came out that said if you have an ultrasound in the 3rd trimester for no indication, that your rate of cesarean section is over 20% higher. Why would that be? Well, it's simply because it leads to the cascade of interventions. It leads to finding reasons to keep bringing you back and ultimately doing more testing and then saying we better induce you. And then induction obviously leads to higher rates of cesarean. The ARRIVE trial be damned. Um, it does.
So
And
can I just insert a question here? Do you think I know when you're saying that physicians are monetarily motivated and that's why more antenatal testing, but my question is, do they see the connection, the snowball effect of that? And do they prefer that snowball effect? Like, good, if we go down this path, we'll end up inducing her. That feels safer anyway. Let's do that.
no, no, they think they're doing the right thing because remember, all that matters to them is
A live baby. The
in the
baby.
bassinet.
Yes.
That's right. That's right. Their job is well done when they have a baby that's crying in the bassinet. And I also use the term bassinet because ultimately it would be better if it was a live baby on mom's chest.
Yes.
But that's generally not what they don't care about that either. Am I being mean? No. I lived in this world. I'm still involved with this world. I may not practice in a hospital, but I talk to birth workers and families all over the world. And I can only honestly tell you that it's getting worse at a time when it gets better. Now, there are changes that are, that give me hope, but ultimately a dying system always pushes back harder. And they're coming out when they find more reasons to do what they're doing. We have, I mean, again, C-section rates nowhere in the world are going down. They're only going up. And our outcomes are getting worse. So that would be the definition of insanity. Doing the same thing over and doing more of the same thing over and over and expecting the result to get better. Right.
But that requires
So that unless there's a true indication,
Hmm.
your fundal height doesn't seem like it's growing well, or it's growing too much, using subjective things like putting your hands on and determining that baby feels really small or it's not growing. Let's take a look and see if we can figure it out. But to do something routinely like that, just to see the baby, I'm telling you and your listeners that depending on who's doing it, it's going to lead to further stress and interventions. Um, so that's ultrasound.
Wow.
It's got its rare indications, and if your doctor is suggesting one for you, ask them why. Ask them how will it change the management any. One of the things I had a great laboratory medicine professor in my 2nd year of medical school, and when we were taking lectures. I wish I could remember his name. And he essentially taught me long ago that you don't order a test unless the outcome is going to change your management any,
Yes.
which is, he was mainly talking about laboratory stuff. Like, don't order a hemoglobin postpartum if the woman is stable, because you're not going to transfuse her anyway. And you're going to send her home on iron probably and vitamins. All right. So if she's able to pee, if she's able to stand up, if she's not tachycardic, what difference does it make whether hemoglobin is 7, 8, 9, 10, and 11? But almost every hospital routinely on the first postpartum day will draw a hemoglobin called a complete blood count mainly, because that's how they're run by the machine. Why do they do that?
Revenue.
That's revenue. It's a long habit of thinking that they're doing something good, but no one stops to think anymore. Does it actually do good? Is there actually a reason? If a woman is unstable, if she's bleeding a lot or if she's dizzy, yeah, by all means. But to have it be routine. So I thank my laboratory medicine professor, whatever his name is. Um, yeah,
So
somebody's going to say that about me 50 years from now. That whatever that guy's name was, I can't remember his name. I feel bad because I should remember his name. Um,
so Stu,
but
that's the question that every woman can ask herself before she accepts a test. Will this change anything that I am choosing going forward?
will
Will
this
this
benefit me and my baby? Correct. And yes, you could always say, well, if you're anemic, then your baby might not be getting this and that and the other thing. But that's, that's like closing the barn door after the horse is already out. You know, did they talk to you during your pregnancy about how not to be anemic? Probably not. They probably gave you a handout to take this, take your prenatal vitamins.
Yep.
They probably don't do diet recall. They don't talk about what your food you're eating. And now in America, what food we're eating, it makes a huge difference.
Mhm.
Finding non-processed food and finding you know, and I always wondered about organic food too. I'm going off the reservation here with this, but
Go for
you know,
it.
they talk about organic food, but how do the bees know which farms are organic and which ones aren't?
I know.
They could fly from a field that's been sprayed with glyphosate into your organic farm.
It is true.
So
I know. I know. There's no perfect. I mean, I think the very best thing that you could do is to eat local, right? Because you know your farmers, you can ask the questions, you can see the food, and even that isn't perfect, but
no, I don't, because who knows where the bees are. I mean, I'm just using that as an example, but the truth is that just because you have an organic farm, it might be next to somebody who's spraying Monsanto's their crops with that stuff. So you just don't know, and and so you can only do the best that you can do. But there should be a reason why your doctor is ordering a test or wants to do these things on you, and your doctor should have the time to explain it to you. And a huge red flag, and you should find this out early in your pregnancy or even before you're pregnant, is how much time are your visits? What does your doctor feel about it? Well, I've put together a whole list
oh,
of um, of things that you should ask your doctor prior to getting pregnant or early in your pregnancy to determine whether or not to stay in that practice or not. And we haven't put it up on our Patreon yet, but it's common sense type questions like, what do you think about me being over 35? What about, do you go past 40 weeks? If I go into labor, are you on call? Simple questions like that.
that's
So,
great. I look
but
forward
they,
to
but they, yeah, but they're, again, the system is designed to work on volume and shift. They've changed it. There are very few practitioners outside of the traditional midwifery model that has continuity of care. And there's really good data about continuity of care and better outcomes. So again, it's not about, they don't really care about outcomes. If they did, they would scrap their whole system, but they
if
don't. So let's talk a little bit about, if you want to, again, about like the biophysical profile or non-stress testing.
let's
Right.
do it.
Okay. Non-stress testing was developed obviously after the CTG machine was developed, and there is data that supports that when there's an indication non-stress testing is beneficial because a perfect non-stress test, reactive non-stress test, is about 99.8% predictive within 1 week that the baby will not suffer
Mm,
a stillbirth.
mhm.
And if you add biophysical profile or maximum vertical pocket ultrasound fluid check, it goes from 99.8 to 99.9. So, should you need testing for whatever reason, and there are medical reasons why testing makes some sense, but it should be an option that a woman has been given information so she can give consent to or not. Then the NST is probably the best way to go, but it's more time consuming. So a lot of doctors, and it generates less revenue than ultrasound does. So they'll want to do an ultrasound, but ultrasound only adds 0.1% accuracy to the NST.
And for those who aren't familiar with NST and BPP, can you break it down? What
Yeah, a
exactly?
non-stress test is where you just sit on the bed, on the table, wearing these belts, and have what's called CTG monitoring, um, or external fetal monitoring. And I don't know that we have the scope to get into the overuse and misuse and lack of evidence to supporting CTG monitoring. But for the sake of a non-stress test, we're just going to say that, we're not talking about labor. So we're talking about antepartum. And you wear these belts and they look at the baby's heart rate over time. And for what they're looking for is what's called a reactive non-stress test. And a reactive non-stress test is a test that really doesn't have any significant decels in it. But 30 to 50% of normal reactive NSTs will have some occasional small decels. And that's perfectly fine. As long as they're not repetitive, it doesn't mean anything. But like anything else, the tech's eyes or the doctor's eyes will go to the one bad thing instead of all the good things. So that's, again, you'll end up with false positives because people don't really know how to interpret them. And what you're looking for is you're looking for the baby to move and the baby's heart rate to accelerate, just like yours would if you ran up the stairs. And they're looking to go 15 beats above its baseline, lasting for 15 seconds, and having at least two of those in 20 minutes. That's considered the standard. And this is for babies beyond 32 weeks. So if there's a potential problem with the baby growth, or maybe mom is truly a type 1 diabetic, or there's hypertensive disease or something, and they think they want to do it once a week, I can't, I can't be that critical of that. If there's truly a concern for the baby, however, a true concern, then it should be done more than once a week. It should be done twice a week. So when a doctor tells you he wants you to have testing once a week, sort of a little clue that the doctor isn't that concerned. It's just it's a security blanket for them. It's a medical legal thing. They're covering their tush, so to speak.
Yeah.
But that's what it is. So if it's not reactive, then that's a potential problem. And then further testing needs to be done, like a biophysical profile, or what they used to do was a contraction stress test, but they don't really do that anymore. It's where they start an IV and they actually give Pitocin to make your uterus contract. So you can get 3 contractions in 10 minutes, I think it is. And then see how your baby responds to the stress of a contraction. But they don't do that anymore. They look at the biophysical profile. And the biophysical profile, the full length one contains 4 elements in it, and you get 2 points or 0 points for each. And that is for fetal movement, fetal tone, a thing called fetal breathing, where you can actually see the baby's chest go in and out, and the amniotic fluid volume. And biophysical profile usually uses 4 quadrants. And if it's 4 quadrants and the fluid volume is over 5 centimeters total, that's considered normal. 6 centimeters is not abnormal. Okay, it's normal. They may say it's lowish fluid. Lowish fluid is not a diagnosis. You can't look that up in a book and find that there's a lowish fluid. But they'll put that out there because then they'll want you to come back in a day or two and do another one. So this is one of the scary things about doing this testing, is it leads to more testing. And then there's the modified biophysical profile, which is just an NST combined with something called the maximum vertical pocket of fluid. Finding one pocket of fluid that's greater than 2 centimeters in depth is considered normal. So that's the testing.
Got it.
I can't hear you.
Oh, you can't? Really? Can you hear me now?
Yeah, you were too far away from your mic, I think, because you have the softest voice in the world.
I know I do, Stu. Oh, I do. Oh, my Lanta. Um, okay, so you feel like there might be more, the NST/BPP might be more efficacious because it actually tells us how the baby is doing.
Yeah, from the reading I did and looking at ACOG's guidelines for these sorts of things and some up to date, the NST is probably the best thing that you can do. But again, it requires more time. You have to be on a monitor for 30 minutes or so sometimes. Maybe you'll be done in 10, but sometimes it may take 40 minutes of office time to do it. Whereas they can do a mean vertical pocket literally in about 1 minute. So, but then NST, like I said, the NST that's reactive is 99.8% predictive that you will not have an adverse event, which is a euphemism for stillbirth, um, within the next 7 days.
Oh, interesting.
And all it does by adding the fluid check into it increases it to 99.9%.
Mm.
Right.
What about, Stu? What if you have a sleeping baby when you go in for an NSD and they're
Oh,
not?
they can do something where they can wake it up. They can either have you go eat lunch and come back, or they can do something called acoustic stimulation, which is essentially just a small vibrator.
Oh,
And they put a vibrator on your belly and it just, and baby's startled. It's like an alarm clock for the baby. And the baby wakes up and it works pretty well, actually.
good to know.
Is it mean? No, probably not. It's no different than, daddy coming over later and putting his lips on mom and saying, baby, wake up. I want to, that sort of thing. It's sort of the same kind of thing. Sometimes actually I used to do that. The
Really?
dad was there. I would have the dad talk to the baby and see if that would wake the baby up before I did acoustic stim.
I
Right.
love I love that.
Yeah.
Okay, so you would actually say this could be a useful test, and when
It's
would
useful for when there's an indication for it.
what would an indication be?
Like I said, diabetic mom,
Okay.
growth restricted mom, a mom with hypertensive disease, um, a mom with true cholestasis, these kind of things, maybe. But to do it just because a woman is 35 years old and she's now 38 weeks, or she's even 40 weeks or 40 weeks in one day or 41 weeks, that in and of itself is not an indication, yet you'll be told that it is.
Absolutely. Yeah, I would say
And you have to decide for yourself. I would tell you that a mother's intuition is really good. If a mother is at 37 weeks and feels like there's something not right about her baby, that's an indication to do testing. If a mother's 41 weeks and she thinks her baby's just fine, that would be an indication not to do testing.
I
If
love
there's
that.
such a thing as an indication not to do something. But you know what I mean by that,
I
right?
do. That's it's the challenge is that every woman who goes to 40 or 41 weeks suddenly is being suggested to come in for multiple NSDs. Sometimes, every 2 or 3 days even.
Yeah, no, I know. Because doctors are nervous.
Mhm.
And doctors think that by doing these things, they're going to be more likely to catch something because they don't know the data. And because they're, for that same old reason we've been talking about the whole podcast. There's no revenue code for not doing something. I often joke, wouldn't it be nice if doctors got paid for not doing
Yes,
something?
right.
Right.
I was reading about how in ancient China, a physician was paid by according to the health of the wealthy client, not paid for when they came and cared for a sick client. I thought that was interesting. So it was to prevention was more important than cure.
Yeah, there's problems with that too, though, because you could have clients who are self-destructive, which then, you don't get paid. But yeah, no, I'm just saying that it would be, if doctors didn't get paid extra, or if they got paid for not doing NSTs or not giving vitamin K or not giving hepatitis vaccine to a newborn or whatever, that would be nice, but they don't. The system is designed so poorly that pretty much everything about it is adversarial to the well-being of the person that's supposed to be being taken care of. pretty much everything that's done to you during your prenatal visits and during your admission to the hospital and during your labor is antithetical to nature's design
Mm,
and does not specifically benefit the mother. Does it benefit the mother when she comes to the hospital to put on a hospital gown? No. Does it benefit her for having an IV started? No. Does it benefit, I mean, again, routinely, does it benefit her to have blood drawn? No. Does it benefit her to be put in a bed and put belts on her? No. The data is very clear that admission NSTs or CTG has had no benefit whatsoever in predicting or changing outcomes. Uh, but they'll do it anyway. All right. Is there any benefit to asking a laundry list of questions to a woman who's laboring, having her sign consent forms? No, these are all for the benefit of the institution, everything that I've said.
mm, mm,
Taking her blood pressure when on admission, that's reasonable. But
mhm.
taking her blood pressure again an hour or two later when it was normal on admission is not reasonable. But they're going to interrupt her to do it because the hospital's policy says you have to have chart of blood pressure every hour, every 2 hours. So you have to, in the middle of she's sleeping or whatever, you have to come and take a blood pressure because otherwise the nurse will get yelled at. It's not user friendly.
It's so true.
And the testing is, if the testing had improved outcomes, this is where it gets down to. Does all this biophysical profile, NST, actually improve outcomes? And the answer is look at the outcomes.
Mm,
We are using these things more than ever. Are outcomes better or worse than they were 10, 20, 30 years ago? And the answer
absolutely.
is they're worse. So they're not improving outcomes. They're making things worse. And just like I said at the beginning, like a broken clock, every now and then they will find something and they will save a baby or a mother's life. That is absolutely true. But how many babies and mothers are being sacrificed because of what they're doing? And if something goes wrong in a hospital because they're doing all these, because the antenatal testing led them to do the cascade of interventions and decide to induce her, and then the induction leads to an epidural, and then hypotension, and the baby doesn't like it, and then they have to give her fluids, and then they start pitocin because the contractions have disappeared, and the baby doesn't tolerate labor well, and she has a C-section, and the baby comes out fine.
Mhm.
Um, how many of them look back and say, we caused that, we did that? They don't. They see a live baby in the bassinet that's crying, and they think they did a good job. Because I can tell you, no doctor or nurse goes home at night. Well, some nurses do, I think, and says, I did some wrong things today. I did some unnecessary things today. I violated informed consent today. I caused trauma in this woman today. Nobody says that. Yet it's rampant. So I mean, the disconnect there, the cognitive dissonance you must have to work in a hospital system and think that you're doing a good job because every now and then you do a good job.
Yes, that
It,
is
yeah. I mean, I
that's
guess that's enough for them.
but Stu, that in and of itself is frightening to be taken care of by people who don't connect to the dots.
No, they don't connect the dots. Because partly because everything is siloed. That's the beauty again of the midwifery model of care, is that the baby belongs to the midwife's care too. In the hospital, once the baby's out, it belongs to the pediatric department. And what happens again to that baby and that mother down the road? I mean, 2 days later, postpartum, she goes home and the doctor says, I'll see you in 6 weeks. So what happens to her for the next 5 weeks and 5 days? They don't know. And what happens to her in her next pregnancy if she had unnecessary interventions led to a C-section? Maybe she moves to another town and then she has a ruptured uterus. Does the doctor who did the unnecessary C-section know that this outcome happened? Would they even connect the dots? No, I mean there's an event that happened in your community last year where a woman had a ruptured uterus and she and her baby both passed. And she'd had a successful VBAC and she had her first baby was a C-section. And I read all the news articles and I talked to the father and I talked to some of the midwives and involved and not involved and just even in your community down there in Arizona. And no one asked the obvious question, which was the very first question that came into my mind, which was why did she have her first C-section?
Yes.
And the
Yeah.
C-section she had was because she had a baby that was breech and
Yeah.
because no one offered her a vaginal delivery. Do you think the doctor that told her that she had to have a C-section, that did her C-section, knows that whether directly or indirectly,
You helped
he's
make it.
responsible?
Yeah.
Yeah.
No, he has no idea. He'll never
No,
know.
no. It's
I
awful to think like that. And I'm not blaming. I'm just saying that they don't think about it. And so they order these tests without any proof that they actually do any good because one, they generate revenue, and two, they cover their ass. And it leads to worse outcomes most of the time. And the system just goes merrily along its way.
wow.
So it's up to the individual women, the people that are like listening to your events and stuff like that, to make wise decisions.
Yeah.
And sometimes you live in a community where you have no choices. Midwifery is illegal, and there aren't any midwives in your community, and the only doctor group there has a 50% C-section rate, and they don't let you go past 39 weeks because they believe in the ARRIVE trial. And if you have a breech baby, you have to have a C-section because they believe in the term breech trial. And the fact is that neither one of those trials they're both poorly randomized trials. And they should not be the arbiters of what a woman decides. She should be given the choices that are reasonable, and it's certainly reasonable for her to have the choice of not doing those things. But they don't know that. And so do they have to move? Do they have to travel? Do they have to relocate? I don't know.
Yeah.
If they want more children, they really should think about it. They should plan this out, not at 37 weeks when they find out that your baby's breech or something like that. They need to plan this out ahead of time.
Yes. So every woman has got to be an educated consumer and not relying on anyone else to
I
tell
mean,
her.
we put more effort again. I mean, I know that these things sound redundant to you and me because we hear it all the time, but we put more effort into what car we're going to buy or what television set we're going to get. We go to Consumer Reports, we read stuff about it, figure it out. Um, but we need to do better. So, I mean, I know that the thing today was about ultrasound and antenatal testing, and I don't think we've solved anything because the problem is there are indications for it, but people are going to be gaslit as to whether or not they really truly have an indication or not. They're going to be told that
Mhm.
because you're 35, that's an indication,
Mhm.
or because you're beyond 40 weeks or 39 weeks or whatever, that's an indication, or because you know, we saw an ultrasound that the fluid was lowish, so we need to do further testing. No, lowish is normal. My baby is fine. My baby's growing fine. My baby's been on the same growth curve all along. How do I know if I haven't had ultrasounds? Well, you check the fundal height. How did we do so well in 1950 and 1960? I'm not talking about 100 years ago or 200 years ago, before we had antibiotics and before we had surgical technique and before we knew some of the things that we knew now. But 50 years ago, we had a C-section rate that was 5%, and we had outcomes that were similar, if not better, than they are now.
And that was before the advent of ultrasound and CTG.
Yep, yep. CTG and the labor curve are probably the two most things responsible for the meteoric rise in cesarean section in the United States, and then everything else has been piled on now. But those two things really changed everything. And what I mean by the labor curve is I mean that this is one of my real pet peeves is the Friedman curve. Um, it says that the average first time mom should dilate a centimeter an hour when she reaches 4 centimeters. Now we've revised that a little bit to 6 centimeters, but still doesn't really matter. The average woman. So how do you get a curve on a graph? You need points. Points on a graph are vaginal exams on this graph. So you need to do unnecessary vaginal exams to find out if you're on the curve. But a curve is the median. So that means 50% of people, women, are below the curve. So according to Friedman, 50% of women are dilating too slowly.
Mm.
And if they're dilating too slowly, and by the way, these were epiduralized women, often augmented in that study. Apparently, there were about 700 women in that study, and it changed everything. But what they're essentially saying is that half of all women are dilating too slowly. We need to augment them. Since when? When did nature have a wristwatch?
Yes, absolutely, Stu.
But the thinking is that all women should dilate at the same rate. That in and of itself should disqualify anybody from being your caregiver if they think that.
That would be a good question to ask, right?
Should all women dilate at the same rate? Yes. What do you think of Friedman's curve?
Yeah, yeah, it's a
And
fair.
and how will you have one on me if I don't let you do a vaginal exam?
Yeah,
I again, I you could we could do this all day. I
Stu,
feel like I feel like Captain America. You know, I could do this all day.
Stu, I think really what it all boils down to is that we've got, as women giving birth, we've got to think about what we're choosing. We've really got to, you remember that old like choosy moms choose GIF? It's the
I
same.
remember that, sure.
Yeah, but
Yeah,
we,
but look at the ingredients in GIFs.
I know it's total crap. Uh, but the bottom line is be a choosy mom. Be the woman who says, no, thank you very much.
It's
And
hard.
it is hard.
It's hard. There's something called the authoritative knowledge of, you go to a doctor's office, you're sitting on a thing, sometimes half undressed. He's standing there generally with a white coat or tie. Um, and he's gone to medical school and he's gone to residency and he's got 15 years of experience and he's going to tell you what he tells you, and you're going to have a hard time looking at him and say, you don't know anything.
Oh, I know.
You can't, I mean, it's very hard for the average person to do that.
It really is. It really is. You've got to sort of gird up your loins early on to do this and start practicing
You've
early on.
got to you've got to put more emphasis on how important it is on how you give birth and how your baby enters the world.
Yes.
And it gets back to that evidence I told you about the chronic diseases in children. It all starts within in the uterus, probably even before that, but with healthy sperm and healthy eggs and all that other stuff. But certainly starts in the uterus. And then how we're born. We've done podcasts about integrating reflexes and stuff like that. And babies that are born by cesarean section often don't have the challenge of coming through the vagina and the twisting and turning that are required for a baby to come through there. And therefore they sometimes will have delayed um, process of integrating their reflexes and developing higher level reflexes because they miss it. It's something that I never even heard of before. I've been practicing 40 years. I heard about it this year.
Makes so much sense.
It's nature's design. Again, when you interfere with nature's design, there are going to be ripple effects downstream. The question is, are they significant now, later, or maybe never? But it is going to change something. Nature didn't design the growing of a fetus, the conception, the growing of a fetus, the labor, and the nurturing of a newborn um, with the intent that it needed assistance. It's that simple. And the doctors can't get it out of their head because of the way they're trained, indoctrinated, and financed. Um, that what they're doing isn't doing good; it's actually doing harm.
Yes. Stu. So buyer, what is it? Caveat emptorum, buyer beware.
Buyer beware, right?
So and I like, instead of beware, I like to say be aware. Think
Yeah,
about
buyer,
moms,
yeah.
be aware that these choosing your testing really does matter. Stu, thank you for breaking all of this down for us today. And what I love about you is you could talk about any of these subjects for hours. And I always appreciate
I know. I do. Well, I'm very passionate about trying to wake up the system, and pretty much everything I can say. Well, everything I can say. I mean, sometimes I say things that maybe I didn't mean to say, but but I can back up.
Mhm.
And another good thing, another way to tell whether your physician is honest on you with you is, one, do they give you the time? We talked about that. But two, are they looking you in the eye? Are they willing to admit that they don't know something?
Yes.
A confident person is very comfortable admitting they don't know something. Hey, I don't know that. Let's look it up. A insecure person can hardly ever admit that they don't know something. And when you get a doctor that, when you say something that the doctor doesn't like, I know you're telling me you think I should be induced next week or on Tuesday, but I don't really want to. And if the doctor starts to get huffy or roll their eyes or say, what medical school did you go to? I mean, these condescending things that they sometimes say, or just their body language. Are they comfortable with that? Saying, yeah, okay. I mean, that's not the choice I would make, but I can understand why you want to make that choice. Let's go with that. Right.
Right. Stu, I was
And then
just
they can go in and then, sorry, Meredith, but I mean, Alicia, but sometimes they can go in then they can go in the lunchroom in their office and they can bitch and
complaining.
moan to their staff about that, about,
Yeah.
that Alicia, she's just such
The
a pain.
typical patient, pain in the
Right.
ass.
Right.
Yeah.
But in the patient, do they give you the respect that you deserve? Remember, as a pregnant woman, you're hiring them.
Yes.
You may be limited based on choices by your insurance company, which is another bad thing, but doesn't mean that you have to deal with this person.
Agreed.
You can fire your caregiver if you have to, and you
Amen.
should. You would never go back to the same restaurant that treated you that way.
Absolutely. And just, I want to add that you can fire a care provider in the middle of your birth if you want to.
It's
If,
difficult.
yes,
They don't have anybody else covering, but you can. Right.
you, you don't
Right.
have,
The hospital's obligated to supply you with somebody.
yes,
Right. It's just very difficult for a woman who's in labor to actually advocate for herself at that point, because that means she has to come out of her primitive brain mode.
yes.
And so that's why it's important to have these things resolved long before that time.
Or to have an advocate with you, to train your partner how to do that, to have an advocate doula with you. So you don't have to do that as the woman giving birth.
Yeah, like I want to give this anecdotal story. I went to Subway in my town the other day. I was out riding my bike and I stopped at Subway. And I went in and I like to order the spicy Italian, which has got a new name now. They changed the name. They always change the name. And I like to have the salami on the bottom and the pepperoni on the top, and then the cheese on the other side. So that when they toast it, the pepperoni and the cheese get
Melted?
the heat. I
Yes.
started to tell the woman this, and she said, "That's not how we do it." And I
Well,
go, "Well, I'd like the pepperoni on the top of the salami." And she says, "How about if I don't make you a sandwich at all and you leave?"
really?
Yep. I wrote Subway a letter. I haven't heard back from them, but
Oh,
yeah, she kicked me out because I asked for the sandwich the way I want the sandwich, which is, I thought, what you're supposed to be able to do at Subway. So I
yes.
suspect this woman was just having a bad day.
Oh, man.
But if this was the only option for eating in town, I wouldn't go back there.
No way. No.
Right.
Yes, women, you deserve more than crumbs for care.
Yes, your doctor should let you make your sandwich the way you want to make your sandwich.
Stu, I love that story so much. I'm gonna
No,
tell.
it was frustrating to me. I was like, "What? You're not going to serve me?" No, I didn't.
Yeah.
And there were people standing in line. I mean, there were people witnessing it. It was like no one raised their voice. I was
Right.
actually in a really good mood. She
Oh,
just didn't like the fact that I said, "No, no, I want the cheese on that side," and I want. But
oh,
isn't that what you're supposed to tell them?
absolutely. And Stu, I just want to add this. My daughter worked in food service for a little bit. She worked at Kava, yummy restaurant. We
Yeah,
went
I
to
know that.
there. We went to lunch there. But anyway, so my daughter Sage worked at Kava, and part of their training is to do exactly what the customer wants. It's like the customer is right every time. That's the central focus. So apparently Subway isn't training their employees, and apparently doctors aren't being trained in that kind of customer service either.
Well, I'm kind of like a woman who's pregnant and only has one option in her town, because it's the only Subway, and apparently she said she's the manager.
Oh, no way.
So I'm totally effed.
Oh, ew. No more Subway for
Oh,
you.
we're Subway and Canab. That's right. Yeah, I was thinking about, again, when that happens, it's like I want to stand in front with a picket sign, say Subway unfair to consumers. But I got better things to do. but it does get you riled up.
It
So if I
does.
was a woman and I didn't and I got disrespected like that, I would
Yeah.
be really riled up about that. I know that when you're pregnant and you're in pregnancy and delivery mode and postpartum mode, you just that's not something on your mind.
Sure.
But if we don't stand up, we get
No,
what we deserve.
absolutely. Yes. Amen, Stu. On that note, Stu, where can everybody find you if they want to hear more from you?
They can't.
They can, Stu. Tell us. Where can
I'm
they?
sorry. I'm in a mood. Um, well, they can find me on Instagram at Birthing Instincts. They can find my website at www.birthinginstincts. And then Bliss and I do our podcast, birthinginstinctspodcast.com, or obviously we're on Spotify and Apple and iTunes on your spot on the Birthing Instincts podcast. And then we started a Patreon. We have a community now of over 750 people in our
Oh,
community, where we put out extra content and stuff. It's in Patreon, and it's I think it's just Birthing Instincts on Patreon.
cool.
And we would love people to come and join us. There's different tiers. There's a free tier all the way up to I think $40 a month for the I don't know. I think they're the medical fuckery group or the we have names for our different groups
Oh,
so and we have a professional group and we
oh,
have yeah. So we're trying to develop a community of like-minded people so that people can go there and ask questions. And we have a Q&A every month. And we have a thing every other month we do called Bringing the Home Birth Hesitant on Board. It's a webinar. And for people that want to have a home birth, but maybe their spouse or their mother-in-law or somebody is really scared about that, they can come on and they can ask questions. And Bliss and I do a little PowerPoint presentation first, that sort
oh,
of thing. So
I love it. I didn't realize that. Wow, you guys are doing a lot. Okay.
yeah, so that's on Patreon, and they can find that at the Birthing Instincts podcast website. So that's it. I don't do Twitter and I don't do TikTok and I don't do YouTube and and I've been on a lot of podcasts. So we have a search engine I think on the website where you can find the podcasts I've been on. So um, that's that's it. I would just like to change the face of birth, even if it's small things at a time. And then I do teach my seminars. I do a 2-day seminar on breech and twin skills for birth workers of all kinds. We would love to have OBs and OB residents come. They often don't. Either they don't know about it or doctors are not just I found that doctors are not interested in learning new skills, partly because their partners or their hospital system won't let them do it anyway. But even that they should want to know as an expert in something you should want to know because every now and then some woman's going to show up with the butt or the foot sticking out of the vagina. And if you don't know what to do, that's going to be a real problem. And as a skilled women's healthcare professional, to not know how to take care of about 1 out of every 16 women that walk into your office, to me would seem unsatisfactory. And I'd be really upset with my training programs who aren't teaching this skill anymore. So
Absolutely. Stu, speaking of the Reteach Breach, are doulas welcome there?
all the time. And I
Okay.
think it's important for doulas, even though doulas are not going to go out and catch a breech baby, if they take the course, not only do they learn how to do it, which is part of it, but they learn so much about breech and twin birthing and about interacting with the hospital system so that I think they can come out better advocates for the women that hire them to be their advocate for. So yes, and there's a thirst for knowledge in doulas and in midwives that just seems to be beaten out of obstetricians.
Interesting.
Yeah, yep. The system will have to collapse eventually. It just has to. We cannot keep going. You cannot have more than 100% C-section rate, and I think that's where we're headed.
Stu. Well, Brazil's almost there, so we could
South
probably.
Africa is close to 80% as well. 80% of women have their baby by cesarean section.
Wow.
And there's no concern about what that is doing to the species, let alone the woman, the baby, and the woman's future risk factors. Um, Going way off topic. I'm sorry. We
Oh,
could talk about
you're
we could talk
great.
about all that another. I could do that for another hour.
I know you can. Stu, thank you so much for being here today with me. So appreciate you.
You're welcome. I love when you do these things. I love seeing you, and our paths will cross again. Thanks for having me.